Now I'd like to invite Dr. Prabhat Dutta. He is an additional director of Heart Lung Institute, CTVS, NSS and Critical Care, KIMS Hospital. He'll be talking on ECMO for perioperative support in lung transplant.
Good afternoon. Thank you, Chair. Thanks, Suresh Rao Murli, for the invitation. This is the place where I work. In 1975, first case of ECMO was used. Then 1991, first case of ECMO used for redo lung transplant, and it was successful. And in 1992, ECMO used as a bridge to primary lung transplant. Since then, we moved a lot, and nowadays we cannot run a lung transplant unit without a ECMO service. Application of ECMO in the lung transplant. In every phase of ECMO, a lung transplant unit ECMO, bridge with ECMO to lung transplant. That is we call pre-op and intraoperative ECMO for during lung transplantation. Usually this is intraoperative use of VA ECMO most of the time, and postoperative ECMO used for the lung transplant when the primary graft dysfunction is there. We call it a PGD. So pre-op and post-op usually is a VV ECMO. Intraoperative most of the time it is a VA ECMO. So bridge to transplant pre-op, the point of consideration, not only running the ECMO, few things extra is there, like patient selection, duration, rehabilitation, allosensitization, infection and exit strategy. So patient selection, every patient cannot be put a ECMO for the lung transplant. Usually already listed for lung transplant, suffer acute decompensation with a moderate functional status. And some post-COVID patient non-recovering for 6 to 8 weeks, we can go for lung transplant. And they all should have a clear potential for recovery, and it should be mono-organ failure with mild impairment kidney failure can be possible. So next is duration, how long? Usually you have to wait, duration can go wait weeks to months. So I give you an example. This patient was put on ECMO on May 11th. We operated on 12th of August after 3 months, and we removed the VV ECMO after 4 days on 16th of August, and then out of ICU one more month. It is 20th of September, and he is out of hospital at 25th of October. So it is more than 5 months in the hospital. If this guy is from Delhi, you can see he is doing physiotherapy in our physiotherapy unit. 44 years gentleman. So duration can be really long, prolonged. So challenges with a prolonged duration, relative and patient counseling should be there, because these patients usually get morally depressed, and you have to counseling should be robust. You have to maintain the nutritional status. You know a patient on ECMO for more than a month, what the nutritional status will be. Rehabilitations, I'll come after this. And we should always look for realistic chance of recovery and availability of organ and cost. Cost usually sometimes goes humongous. As you know, on the transplant patient on ECMO per day cost goes to 75,000 to 1 lakh. So at the end of the day, transplant after 2 months if you do, bill goes nearly to crores. So rehabilitation, you should always emphasize our rehabilitation. More your rehabilitation program, it will be there. See, this is the way usually our team does rehab. We have a robust physiotherapy team. They upper limb, lower limb, everything they just mobilized. So more we invest in rehab, better will be the outcome. We put up CentiMax through the neck and patient will mobilized. Most of the time we try to get a neck cannula if possible. Awake breathing advantages, avoid deleterious effect of mechanical ventilation and sedation, allow mobilization, improves organ functions and general status, provide optimal condition for the lung transplant. Second problem is allosensitization. When a patient is on ECMO, usually they receive the blood transfusion. So multiple blood transfusion can cause the antibody production. So before this patient may be pre-op, when you are assessing the PRA may be negative, but if you plan to go transplant, you should always cross-check the PRA again. See, this patient on 13th of September, patient on ECMO. So mid of October, we decided patient can go for transplant. So 27th October, we recheck his PRA. PRA class 2 was 67% positive. As per our protocol, we did the plasmapheresis and IVIG, and 7th of November, his PRA came negative. And luckily, we got an organ on 10th of November, and we operated, and next day we removed the ECMO. Same day. So, but the problem was when they got a cross-match sample in the night, it was class 2 mildly positive. So we did a early biopsy for him. You can see he's doing a physio in our physiotherapy department. So we have a small protocol for the allosensitization. Recheck PRA level if patient receive multiple blood transfusion on ECMO. Plasmapheresis and IVIG if the PRA is high. Recheck the PRA level after the plasmapheresis and IVIG. and try to get a prospective cross match. But it is possible only when it is an in-house donation or inter-city. If outside city in India, it is not possible at present, and post-op early biopsy before discharge. Infection. So this is one of the enemy for us for transplant. Pre-operative recipient should be infection-free. As you know, post-op transplant, this patient either go bacillus or ATG for immunosuppression. Any mild infection also will flare up, especially the fungal infection. So what we follow usually, strict isolation room, 1:1 nursing, regular biomarker, usually procal and others, serial cultures if required, ID specialist will come for rounds for these patients, and antibiotics as per requirement. So whenever you put a patient for pre-op ECMO, you should always have a exit strategy. Bridge to recovery to recannulation, decannulation. We have seen most of the time of the COVID patients, decision, if there is a single organ failure, you go for lung transplant and then remove the ECMO. But if at two or three organ dysfunction like kidney and all, usually if we do dialysis and all, sometimes young patient kidney recovers. But they got multi-organ sepsis or CVA. In that case, will lead to palliative or withdrawal of the treatment. So this is the paper they presented, factor affecting post-transplant survival patients on ECMO. So favorable factors less than 50 years, normal or marginally increased pulmonary artery pressure, less than 14 days of ECMO, low SOFA score, non-invasive ventilation, and patient's ability to participate in the physical therapy. If these factors are there when the patient is going for transplant, your outcome will be always good. But unfavorable if age is more than 60, Willi is more than 3, ECMO run more than 14 days, except I can tell what we see in the COVID patients, severe pulmonary hypertension, prolonged mechanical ventilation, and SOFA score is more than 9. If these factors are there, your post-op outcome may not be a good. This is a paper presented by Toyota for the efficacy of extracorporeal membrane oxygen as a bridge to lung transplant. He showed that ECMO is efficacious as a bridge to lung transplant with a good post-lung transplant outcome. Next, come to the intraoperative ECMO for lung transplant. Usually we do the VA ECMO most of the time, and indications are RV dysfunction, severe PA pressure, prolonged ischemectomy expected more than 8 to 10 hours, borderline organs where the PF ratio is less than 300 or some repooling is there or some condition is there, the retrieval team informs you, you plan it, patient may need to go for ECMO longer time, and some institutional choice. So this is the paper they presented for the intraoperative MCS for the lung transplant compared to VA, VV and CPV. See, recirculation is more in VV, hemodynamic support better in the CPV than VA ECMO. ACT you have to maintain more in CPV. Cannulation, CPV is central, VA either peripheral or central. Priming volume is large in CPV, but CPV has one advantage, it has a reservoir, but its most disadvantage is a very few hours. ECMO you can run for longer time. Advantages of intraoperative ECMO: avoid hemodynamic instability, centrifugal pump, less inflammatory response, post-operative prolongation possible. So usually, as we know, when we do the patient ECMO, we don't have reservoir. To overcome that, we can use a cell saver. So this is a sovereign cell saver. In our institute, we use it. Another modification you can do with a hybrid ECMO configuration, you can attach a venous reservoir in the ECMO circuit. Only problem is here the venous drainage is gravity dependent. You cannot put a suction in this. Weaning of ECMO post lung transplant. See, ECMO weaning is always same protocol to follow. These are the little extra during specific to the lung transplant. You have to do a bronchoscopy before weaning and see the bronchial anastomosis side. See there is any repooling is there or not. We call it PGT fluid, and any robot rotation or torsion is there before coming out. TE, like any other de-airing, everything you see, but anastomosis gradient, especially the LA gradient, you have to see both the side bilateral. If it is there more, you have to ask your surgeon to go and redo it. Otherwise, the ICU will be nightmare. RV function, you follow it up. PA pressure when you wean, it should be at least less than 1/3 of the systemic. You ventilate as less as FI2 as possible, around 35%. When before coming up, ABG minimal should be PF ratio should be more than 200. And in our institute, we give before giving protamine, we do 2 ABGs 45 minutes apart and see the incremental increase on the PF ratio. There is a meta-analysis for ECMO versus CPV. In 2017, meta-analysis shows this is for intra, only ICU length of stay was shorter in ECMO group. But 2018 they shows lower rate of PGT, lower rate of bleeding, lower ICU stay and hospital stay. So this paper shows that ECMO is better than intraoperative use of ECMO for the lung transplant. Indication for ECMO post lung transplant, usually it is a primary gut dysfunction. and it is the multifactorial. The recipient factor is RV and LV dysfunction or PH. If it is pre-op, this there for the patient, better keep the ECMO ready. Marginal donor or prolonged ischemia, and post-op for PF ratio is less than 150 or PF pressure is high. In this case, both the cases you can call VV ECMO, but if it is hemodynamic unstable, you have to go for a VA ECMO. So this is a patient on VA ECMO. Later on, we remove it to the peripheral VV. So pre-op patient was on a VV ECMO and successfully done this. Then ECMO for PGD. This patient, this is the X-ray of a patient who was on COVID but not on ECMO for nearly 3 months on ventilator with tracheostomy. So we did a transplant. Post-transplant, you can see the right side X-ray. We put a ECMO because of the PGD. After 4 days, his X-ray improves. So we removed him and he is on a tracheal mask sitting in the ICU. This is another photos. This for ECMO to PGD. This is our institute what we did last 1 year, 13 months. 26 COVID patients are transplanted. Intra, all of them are done on VA ECMO. Post-op for PGD, 7 patients was on VV ECMO. Non-COVID, 4 patients were done on ECMO. These are most of them ILD except one paraquat poisoning. Intra, all those done on VA ECMO. And post-op, out of 44 non-COVID transplant, 4 required a VV ECMO. This is the ISHT paper from my colleague Dr. Sharanya presented last month, outcome of ECMO as a bridge to lung transplant, experience from India. It is 2017 to 2020, when we were in global, that time paper. 18 patients was on ECMO, 14 transplanted, even 9 survived. So conclusion, ECMO requires a comprehensive team approach. In this team approach, your most important part of it is nursing staff, perfusionist and physiotherapy team. ECMO is a viable option for selected pre-lung transplant candidates. Central VA ECMO is preferable over CPV for intraoperative support. Outcomes for ECMO as a bridge to lung transplant can be comparable to non-ECMO lung transplants. These are the reference. Last week, our surgeon came with ex vivo. Thank you.